cute talent.
Well, hi everyone. We are back at Community Journal, and I am Barbara Ann Foley, the Council on Aging Director, and we are really fortunate today. We've got a great show for you. We have two of our new friends, Suzanne Faith, who is a nurse and clinical director at Alzheimer's Services of Cape Cod and the Islands, and Vaughn Harding, who is a licensed social worker, and he's the director of a wonderful program there called Hope at Home, also with Alzheimer's Services. And we're going to talk today a lot about Alzheimer's, a lot about memory, and a lot about questions that you probably all have at home. And one of those things, nobody wants to touch that subject of memory loss. So we're going to do it for you, and hopefully we'll answer all of your questions. So, Suzanne, we have a lot of residents in our community. Harwich, we're told, has the fourth highest population of Alzheimer's on the Cape. And obviously people are very concerned about memory loss and how do I know if it's really Alzheimer's or really memory loss? The old joke is, well, if you can't find your keys, then there's a problem. And then others will say, no, it's not a problem. It's just if you find them and you don't know what to do with them, then you have a problem.
Yes.
So how do you know?
Well, usually there are many components to getting a diagnosis, and it's really important if you fear you have a memory problem to perhaps first call us or speak to your doctor, and then really the components of getting a diagnosis include a history of your memory problems over the past couple of years, so your social history, a medical workup, because there are many diseases that can mimic or have as a side effect memory loss. Some medications can create memory disorders, so we want to make sure that you get screened through that. We do have memory screens that will tell you initially right off the bat if you should pursue any further diagnosis. You want to do a neuropsych exam, and the last thing is you want to go to a neurologist and get probably an MRI. MRIs are more sensitive to brain imaging for memory impairment than a CAT scan, but either will do.
So if you go to a general practitioner or your primary care physician and start there, and you say, I've had some memory issues, what do you do if the primary care says, well, take XYZ medication? Because that happens a lot, no?
It does, and actually now with the new health law, everyone that requests it should be able to get a memory screen done by their physician. If for some reason their primary care physician is not going to do that or doesn't feel comfortable doing it or isn't prepared with the test in their office, you can call Alzheimer's Services. We will do it free for you and then give the results to your primary care physician.
And we do have the memory screening done here as well on an annual basis, which is obviously wonderful and very convenient. So, Vaughn, is there a difference between, we hear the word Alzheimer's bandied about a lot, and then you hear the word dementia, and I think everybody thinks that Alzheimer's is the only form of dementia. So how do you know what the difference is, and is there more than just Alzheimer's?
Absolutely, Barbara, there is. Alzheimer's is just the most common form of dementia. There are over 70 different types of dementia that can have different bases, but as by far as 50 to 70% of all dementias are Alzheimer's, followed by vascular dementia, which is about another 10%. And Alzheimer's, of course, is typified initially in the early stage by memory loss and having problems identifying things, objects, if you will, some disorientation and of that ilk.
So when my father, I think everyone out in TV land knows, had Alzheimer's for 10 years, and one of the first symptoms that as a family we noticed was his checkbook issues. They had lived in Florida, and he had a swimming pool, he and my mother, and he would pay the swimming pool company that came out and cleaned and such twice in the same month. Those were where issues came up for him. So I'm sure that there are many different ways that the memory loss and issues manifest itself. But another that we get phone calls about here at the council a lot in our outreach department are sometimes people will call in and tell us that a neighbor or friend or family member is driving erratically or not well, too slow or way too fast, or going through stop signs or that kind of thing. And sometimes they will talk to us also about some paranoia, thinking that someone is stealing from them, or because they've misplaced those items that you were talking about. Maybe they don't know where they are or where they put them.
Exactly.
And so if we take that forward and we are going to now say, well, okay, I'm the daughter of, or I'm the sister of, or I'm the spouse of, how does one get that loved one started with help? How do you, I guess, start the conversation is one of the wonderful Alzheimer's seminars that they do. But it isn't a simple thing, I can tell you as a daughter, to try and have somebody admit that there's memory problems. Excuse me, the phrase my father used to use in the beginning was, my remembery isn't working.
I'm remembering.
And he didn't say remembering or memories, but he combined the two words. And that's when we all kind of said, oh my God, like, where did that come from? So what would be a good starting point? Obviously, if they sort of made the secret phone call to you, if they were a spouse, but how does one, you all have that expertise, get them there?
The situation that you just presented is probably the most common scenario that we receive in terms of phone calls in the office. And, I'll answer that, but going back to, how do you know if you really have a problem? Actually, people that have the beginnings of Alzheimer's disease often aren't aware that they have memory loss. So if you think you have memory loss, it's usually a good sign that you're probably okay. But if you go through the front door with if I, for instance, said to you, Barbara, I'm concerned you seem to have some memory loss, or Mom, or, we're sisters or something, you would deny it adamantly.
Right. And
so a lot of it is, we at Alzheimer's Services, we can meet with the family, and actually, hopefully we'll talk about the Hope at Home program, but we'll meet with the family first to help you develop some strategies in figuring out how to approach the situation with your sibling, parent, spouse, so that you'll have a successful outcome. And that's what it's all about. And if you don't do it right, you often create the paranoia that you're talking about, where they get suspicious because they think they're fine.
Right. Or angry.
Yeah.
That's the other emotion that comes out a lot.
Yeah.
And we should also mention that here at the council, obviously Alzheimer's is an area of expertise after 25 years of working with it. But we have wonderful outreach staff as well, and they can help you to start the conversation. They can be that third-party bad guy that says, perhaps we have to work on license being taken away or removed, or setting up an appointment with a third party and making the connection to Alzheimer's Services, even if it's needing a body from Alzheimer's Services to come here to the council. They've been wonderful and done that before as well. So I think the bottom line message on that piece of this conversation is, you absolutely are not alone. You may feel like you are, but please, please, if you take nothing away else from today, know that you are not alone, and Alzheimer's Services is a partner walking through this with you, as is the Harwich Council on Aging. You both mentioned that sometimes there's other diseases and conditions that can mimic dementia, and I know with some women there's things like urinary tract infections that can present some issues that may present some confusion with it. Some B12 deficiency may present some problems. In my father's case, we had alcoholism as well in the picture. So, of course, I have 6 siblings, and all of them were saying, it's just his alcoholism. It's just an exacerbation of that part brain. It's not what you're thinking. Just because you work with it doesn't mean Dad has it. That's what we received a lot of. So there are a lot of things out there. And I think in the beginning, working with Alzheimer's as a partner, it is a lot of ruling out before we rule in what it is, if I'm not mistaken, yes?
Yes. That's why getting a medical workup is so important.
So when the difficulty that I find a lot is that I had asked you previously is that families will take their loved one to the primaries, and the primaries will issue them or give them an Aricept or give them a medication, and a workup isn't necessarily done. Yes. And if it is something like a B12 deficiency or a urinary tract infection or alcoholism that the doctor doesn't know about, we're really doing that patient a disservice. Right. So you need to be really great advocates. It's very difficult, obviously, and we're certainly not condemning physicians. It's just they're trying to be the best that they can be and be helpful. And sometimes there's some little steps that get missed. So we want to make sure that you do connect with Alzheimer's services. And if the primary care is, issuing a medication, to question that. What is this used for, and why would my loved one be taking it, and are there other steps that should be done, such as getting some screenings done and getting some medical testing, as you had said.
And one of the problems that really gets missed often is depression.
Absolutely.
Depression, the beginning stages of Alzheimer's disease and the behavioral problem of depression look almost exactly alike in the beginning. And doctors will not necessarily screen for that either. They think, well, yes, you're older, you're going to have losses in your life, so who wouldn't be sad?
Right.
But, the chemistry of the brain changes as we age. And the chemicals and everything in our brain is based on the chemical reactions that are going on in the brain. Those chemicals become depleted and people become clinically depressed. You see that, I'm sure.
Absolutely.
The other issue is that we have, and I had myself, because, now I had a grandmother, paternal grandmother, with Alzheimer's disease and late onset diabetes, which they're now seeing the wonderful connection between the two, and my father. So right after my father died, I went through the terrible grief that everybody goes through when you lose somebody that you love, but it was so severe that I started having some forgetfulness and I had conversations with people after my mother passed away that I have no recollection that I had. And it was absolutely frightening. And I'm thinking, okay, so now am I getting Dad's disease?
Yeah.
I mean, I really was truly worried. And so I'd caution you also to ask, if you have just lost a loved one, to talk to your doctor about grief, because it very well could be that some of the exacerbations of grief, sadness, and depression could be what's going on, and it may indeed not be memory loss or Alzheimer's. So I think we've pounded home, certainly, that we need to get some medical intervention and not necessarily just the primary care. And when you mention the chemical changes in the brain, one of the powerful, wonderful ones are endorphins. So one of the ways I know that you can raise those or work well with them is exercise. Is there anything that we can do to keep ourselves from getting Alzheimer's or having brain problems?
Yes, absolutely. Today, it's important to understand that whatever is heart healthy is also brain healthy. So exercise 4 or 5 times a week, even something as simple as walking and getting out and getting some fresh air can be critical, and keeping your mind active as well. There's plenty of literature today that shows that people who read and keep themselves mentally active and in social settings tend to do better, even after a diagnosis. So you can be
Well, I
critical
will
of
tell
all
you,
this.
we have anyone watching that lives in Harwich has zero excuses not to be able to exercise. And the reason I say that is there's a number of them. We have a brand spanking new, awesome walking track right outside of our building. We have some new ball fields out back. And if you haven't strolled up there, I would urge you to do so. We have a ADA compliant track that you can walk on, and I'm told 3 times around is a mile. We have an indoor walking group, we have an outdoor about town walking group, and we have about 9 different exercise groups. Some that are sitting, we have 2 forms of yoga. One is a regular yoga, standing, traditional, and the other is a sitting chair yoga. We have exercises for balance like Tai Chi and yoga and Qigong. So we have the Cranberry Coach van that can bring you here if you don't drive any longer. And as long as you are physically mobile enough that you can move your arms and legs, even if it's sitting in a chair, there is exercise that you can do. We also have a nice little booklet here at the council for exercises that you can do at home. So if you happen to be a homebound person and you have a neighbor that could come pick that up, or you'd like us to mail it to you, we can do that, and you can do your exercises at home. So truly, there is no reason that you cannot have some form of exercise, even if it's walking around the house and doing a little bit of stretching with the exercises in our booklet, or physically coming here. And the other component, I think you'd probably agree, Vaughn, that goes with exercise is the sociability. If you're exercising, it's always greater or more fun even if you can exercise with a partner or with somebody. Here, you don't have to necessarily even know someone. The group that goes around in the gym, there's anywhere from 8 to 20 of them, and they all carry on with each other, and several of them meet that day. They don't even know each other. And the track certainly out back, walk with a partner, walk with a friend, or a neighbor. It's a great way to get to know people as well as to get some exercise out in the fresh air. So there truly is no excuse. We have lots and lots of exercise programs here. So we've talked a little bit, Suzanne, about what you do to sort of get the diagnosis, how you make the steps to get there. But why don't we talk a little bit now about once you receive that diagnosis?
Well, once you receive the diagnosis, it's frightening. It's frightening for, it can be frightening for the individual, depends on their ability to be aware that they have a problem, because many people don't bother to get the diagnosis till they're way progressed into the disease. But once you get the diagnosis, the most important thing beyond the one-on-one counseling that we can do is to join a support group. And you have a wonderful support group here, where there are 26 support groups on the Cape. And so it's joining a support group and then sitting with maybe your outreach worker or one of us from Alzheimer's Services to develop a care plan to move forward, because whether it's Alzheimer's disease, vascular dementia, or any of the other 70 forms of dementia, most of them are progressive. Right. And the sooner you can develop a care plan around, getting your legal work in order, getting your health care proxies, getting your power of attorneys, getting all of that done, you can move forward in the disease with the support that you talked about earlier. And you should be able to manage all of the various crises that happen as the disease progresses without falling apart.
Well, the Alzheimer's Services, I'm not sure if it's still on goldenrod colored paper, but they have a wonderful single sheet that we use all the time that has 2 columns. And one of the columns says what the Alzheimer's patient is going to look like, what they're going to go through, signs and symptoms and things to expect. And the other is what the caregiver is going to go through and what they're going to look like and signs and symptoms to expect. And it's a wonderful tool, because I know that one of the things that they had on the caregiver side, that my mother went through was a depression of her own, as to the fact that she lost this very powerful IBM executive husband, partner of hers for 58 years. She knew she was going to be losing little piece by piece, and it's very traumatic. And if you don't know what to expect, and you don't have either or both Alzheimer's Services and the Council on Aging as your partner walking through this in your life with you, you may not know the symptoms. Just getting a diagnosis and then saying, okay, take this medication, and now we found out you have tangles and plaques, okay, so where do we go from here, isn't helpful, because you need to know what's next and what to expect. My worst best case that we have, that I tell everybody, and I've said on the show before, is a husband and wife who did not have any of the planning done. They did have a will, but they did not have healthcare proxy and definitely didn't have power of attorney. They needed to move to another state to be closer to their children, and they were going to go to an assisted living type of complex that also had a nursing facility so that they could plan for the future. Wonderful plan. However, the disease had progressed so much that both husband and wife were on the deed. And they ended up having to spend $30,000 in order to have the house be able to go up for sale. It all could have been avoided, as the lawyer said, in a $300 document or something like that with a power of attorney. So I do urge you, and we've talked a lot on this show with various attorneys about the documents and getting them in a row. And you can certainly call us and ask for what those documents are and that kind of thing if you do not know. But everything from the Homestead Act to a will to your power of attorney with an Alzheimer's patient is absolutely critical. And if it isn't done before the diagnosis of the person, it definitely needs to be immediately once you get that diagnosis.
And the sooner these supports, legal and emotional, are set up, the better you are, because Alzheimer's disease specifically is probably anywhere from 6 to 12 years is the average lifespan of somebody that's gotten the diagnosis. And everyone at some point in the disease is going to become somewhat dependent on their physical care needs. And so these documents and getting your plan in order help prepare you for that down the road. And if you're going to stay in the community, what's that going to look like, and who is going to be the support in the community. And the state has done some wonderful programs in recognizing that, you know, it's far more cost effective to keep people in their home than have them go to a skilled nursing facility, but you've got to plan for that early.
You also, in being at home, is the familiar surroundings.
Yes.
And then when you remove someone, we had to, after my mother died, move my dad up here from Florida. And that home he had known for over 20 years. When he came here, first he was with me, and then next door to us in a couple of different places in order to get him situated. It was very difficult because he was mid-stage at that point. So familiar surroundings are very important. And if you can keep the person at home, it's very important to be able to do that. And again, with the partners, they can help you to figure out how to maneuver the system so that you can get all your ducks in a row and be able to do that. One of the questions we get all the time is, well, I'm old. I'm 80 years old. My grandma was, I think, 84 when she was diagnosed. And back then they called it senility, and they said it was, you know, you're old. That's what happens when you get old. Is Alzheimer's largely age-related?
You want to take that?
Yes, it is. It largely is, but not solely. First of all, people should know that there's roughly 10,000 people on Cape Cod alone with Alzheimer's or related dementia, which is kind of a staggering figure. But there is an early onset form, which is generally considered to be more genetically related than perhaps environmentally related. Most people are considered to have early onset if you're diagnosed before age 65. And in fact, we have a new group that we've just started to work with folks who are newly diagnosed and fall into the early onset category.
Oh, that's wonderful. And I will tell you, too, just a reminder that the CARES group that meets here has two components to it. It's on the first and the third Wednesdays of each month. I believe it's at 10:30, but you can double check me and call the Council on Aging to make sure. But the two components, one of the reasons that people often don't go to support groups is because they don't want to spend the money to have somebody go to their home to take care of their loved one while they go to the support group. And what's phenomenal about this particular CARES support group is that the patient comes too. And the patients are all in one room with a nurse, and the caregivers are all in another room with a nurse. So the caregivers are getting some help and some needed guidance and sharing of, what works for them and how to get through the holidays and that kind of thing, while the patients are also going through their questions and their symptoms and things. So it's a wonderful dual process, if you will. And I think that's why it works, is because they're able to bring them.
Yeah. And people think that support groups, they go, I don't want to go to a support group, I have enough stress in my life, I don't want to listen to anybody else's sad story, but support groups is where you learn the tools to manage the disease. And hearing other people's stories and how they got through a particular situation often will help you as you're going through your own situation. So I highly recommend.
I kind of equate it to a new mom. When a mom has just had a child, and I take the temperature, and then what's like the highest it should not be, or I change the diaper and this is what happened. Any of those nuances are all going to be nuances in taking care of somebody with dementia. And so just like if you were in a mom's group or a play group and you're all chatting with each other and learning things, or a teen group later on, you all have helpful hints that have worked for you or not worked for you that you don't want to repeat. So it's very, very helpful for both parties. The other thing that we hear is it automatically genetic? And I know, having two family members, we have 7 kids in my family, and all of us are constantly second-guessing each other, saying, God, do we have Dad's disease? You told me that yesterday. But often when siblings chat with each other, especially girls, not to sound prejudiced, but it's true, you don't remember which sister you told that to. So it doesn't necessarily mean it's dementia, it's just that you're chatting with each other all the time. Right. So, but there is the early onset form, and that is largely believed to be genetic.
Correct.
If I'm not,
Exactly.
Yes.
Right. And we have we've had them here on Channel 18 before, the famous Noonan family, which is the Cape Cod more known family with early onset, and what that looks like. It's also equally as dreadful, but much quicker in its length or duration. One of the sad things about the disease is that it's labeled with often is aggression or fighting or anger. And people said to me in the very beginning, oh, you've got to be really careful and really do, your strength training exercises, because your dad's going to be like, swatting at you, and you're going to need to be able to defend yourself. And I remember being so angry when people said that, because I knew in my heart that not everybody has that or goes through that. And it's not one of the common symptoms that, it can happen, but not everybody has it happen. Is that correct?
And everybody will progress through the disease differently, and one of the reasons that many of the behavioral problems occur is because one of the things that's lost early in the disease is the ability to communicate well and understand what's being said to you. And the Hope at Home program that we have, where Vaughn is the director, Vaughn and Molly, his colleague, will go into the home and work with the family to teach them tools that will help you communicate better with your family member. It's covered by your insurance, and if you'd like to know more about it, you can call us. But
So would they call and ask for you, Vaughn?
Yes, they could. We have a person, Mary Hartford, in our office who will usually screens those types of calls and then passes on the information for me for further assignment if people are looking for services from the program.
And is it, so it sounds like it works also at home with both parties, the caregiver and the patient, or is it one or the other?
Primarily the caregiver.
That's okay.
Because it's a clinical program and billable to someone's insurance.
Okay.
We have to ensure that it's someone that can benefit from the therapeutic interventions that we suggest. So generally, it's a program that's trying to answer the question about who's taking care of the caregiver. But yes, we do have a couple of folks that are early enough that we actually have them are the direct clients.
Well, the other thing I will end with is that in addition to Alzheimer's Services, another partner that you want to know about at the end of the road, as they say, or the long road. Some call it the long goodbye. It's got lots of awful titles. But when the patient gets much more difficult to manage and they're not in the early stage, it's time to find yourself having a conversation with hospice. And a lot of people forget that hospice, one, is not only for cancer patients, and two, it's not only for the last week of your life. And unfortunately, they get brought in sometimes, it's never too late, but they could have been brought in earlier. And because they are a partnership now with Alzheimer's Services and hospice, I would just ask that you keep that in mind. It's an ugly word. A lot of people don't like hearing that word because they associate it with cancer. But it is a Medicare-covered service, and it's something that not everyone knows about in the world of dementia when you're at home. So I would just mention that it's an important link towards the middle of the road.
And because the length of the disease is so long, hospice is there to improve the quality of the end of your life, and
Absolutely.
they come complete with their own team of social workers and nurses and doctors and home health aides and everybody to keep you in the community longer, or if you end up having to go to a skilled nursing facility, they will follow you there.
And comfortable.
And they're not mutually exclusive either. Hope at Home, for example, we can continue to work with the caregiver while hospice is providing their services as well.
Well, I can't thank both of you enough.
Thank you.
It's a wonderful education. There's so much to know about the world of memory loss and Alzheimer's and dementia. And hopefully we've answered a few of your questions. But I will tell you that I'm sure that Jamie will have posted the 508-775 5656. I knew it was an easy one to remember, and then I forgot it. 775-5656, number for Alzheimer's Services. And of course, you know our number here at the Council is 430-7550. And you can always talk to Betsy or Beth in our outreach department. And Alzheimer's Services, you can always ask for either of these wonderful people, Suzanne or Vaughn, in the programs that they do. And if you have any questions, please don't hesitate to call us. That's what we're here for. So thank you for tuning in, and thank you both for being here.
Thank you.
Thank you.
Appreciate it.
Thank you.